We currently have 30 participants.
Excellent.
My phone says 9:57 and we'll start promptly at 10. Hopefully by that point we'll have the majority of people who plan to join us.
So Bruce, you made it home and got cleaned up?
I didn't get cleaned up, but I made it home.
I'm willing to bet you didn't wear a shirt and tie last night.
I did not, no.
Hi, everyone. I'm going to be off video and mic until I come in the end, but I just wanted to say hi and thank you all at the beginning.
Great to see you.
Great. Good morning.
Good morning.
David, do you have earphones? Because, yeah, thanks. I'm holding 74.
It's non-fattening, right?
Rabbi Perkins says good morning.
Which Rabbi Perkins? Oh.
The one who knows you.
Ah, Rabbi Clayne Perkins. Actually, could be either. Good morning.
So he answered, it's Rabbi Carl Perkins.
Good morning.
All right, I have 10 o'clock and we're at 121 participants. So I'll begin while people are coming on board. We welcome you to the Synagogue Council of Massachusetts webinar, Opening Our Synagogues. My name is Gretchen Marks Brandt. On behalf of Synagogue Council, our director, David Bernat, and our board of directors, it's my honor to welcome more than 240 participants representing almost 100 synagogues and organizations from throughout Massachusetts and also Maine, New Hampshire, and New York. Last week, Governor Baker announced the opportunity for synagogue openings statewide. As we look toward the coming weeks, the summer, fall, and high holidays, we wonder, what's next? What's our path forward? Can we open, and if so, what strategy will enable us to responsibly serve our communities and maintain physical, emotional, and spiritual health? This workshop has been designed to address these crucial issues. While the essential message is that it may not be advisable to open our synagogues at this time, we continue to plan for the day when it will be safer to do so. A few months ago, before we all closed, Ethan Mascoop reached out to Synagogue Council and offered his experience and expertise in providing resource materials for synagogues in preparing to meet the challenges of the day. We are so very grateful for those resources, and they're on the Synagogue Council website available to you. We are abundantly grateful to Ethan, who said, yes, when we asked him to participate in this webinar. Then Ethan decided that more voices were needed, and he coordinated our panel of public health professionals. This extraordinary team, all of whom are also active in synagogue life, will facilitate our forum today. I'd like to introduce you to our distinguished panelists. Ethan Mascoop, MPH, RS, is an adjunct clinical instructor of environmental health at the Boston University School of Public Health. Ethan was a former health director for the town of Framingham. He currently works as an independent consultant for large institutions and boards of health in Massachusetts. He's also a consultant and supplemental health agent at the Sherborne Board of Health. Ethan received his Master of Urban Affairs from the Boston University Metropolitan College and a Master of Public Health degree from the Boston University School of Public Health. He has been the Baal Koreh for Temple Re'im for more than 40 years. Jonathan Slutzman, MD, is an instructor in emergency medicine at Massachusetts General Hospital and Harvard Medical School. He holds a BSc in Civil and Environmental Engineering from Princeton University, an intern engineer certificate from the State University of New York, and an MDA with distinction in disaster medicine from the Albert Einstein College of Medicine. He has completed work on medicine and nuclear war, suburban flood hydrology, healthcare, cost modeling, and environmental life cycle assessment of healthcare processes. His academic focus is on the costs, both financial and environmental, of healthcare. He is a founding member and chair of the Partners Healthcare Clinician Sustainability Group, a past chair of the Society for Academic Emergency Medicine, Climate Change, and Health Interest Group, on the advisory committee of the Healthcare Without Harm Physician Network, and a founding member of the Mass General Hospital Executive Sustainability Committee. A member of Congregation Kehilloth Israel in Brookline, he is chairperson for emergency preparedness there. Wendy Hager-Bernays, PhD, is a clinical professor of environmental health at the Boston University School of Public Health, where her research and teaching focus on impacts of people's environments on their health. Dr. Hager-Bernays serves as the chair of the Lexington Board of Health and has convened an advisory board of epidemiologists, exposure assessors, and infectious disease physicians with whom she communicates daily as the COVID-19 science and policy unfold. She is an active member of Temple Emunah, and her children attended JCDS and Gann Academy. Bruce Weinstock, MD, MPH, is boarded in general pediatrics and pediatric emergency medicine and is currently chief of pediatrics at Norwood Hospital, a pediatric emergency physician at Mass General Hospital, and instructor at Harvard Medical School. He has held clinical and administrative positions with Boston Medical Center, Steward Healthcare, Boston Children's Hospital, Mass General Hospital, has served on the Massachusetts DPH Emergency Medical Services for Children Task Force, and has been medical director for Norwood Public Schools and multiple other community camps and programs. He is currently a member of multiple local synagogues, including Young Israel of Brookline, Temple Sinai Brookline, Congregation Kehilloth Israel, Newton Center Minyan, Congregation Mishkan Tefillah, Minyan Shalem, Washington Square Minyan, and Minyan Korina. Thank you, I'm sorry. Before turning it over to our panelists, I'd like to share the plan for this morning's webinar. The webinar content is divided in 3 sections. First, each of our panelists will present individually. Next, as a panel, they will address a number of prominent questions collected from the webinar registration form and survey. The third section will be an open Q&A. As questions arise for you this morning, please post them in the webinar Q&A. David Bernat will close our program this morning. Once again, we are so grateful to be together this morning. I'm turning it over to our panelists now.
Thank you, Gretchen. If I could have the first slide of the PowerPoint to be displayed. Great, thank you. Again, thank you, Gretchen, for the welcome, and to the Synagogue Council for inviting us to discuss this timely and important topic that we are all struggling with. Also, Gretchen, thank you for introducing the panel. I'm looking forward to hearing what they have to say, and I'm humbled to be with them this morning. This is the first time in memory, and perhaps the first time in Massachusetts history, that the Commonwealth has exercised its police powers to shut down all places of worship due to an emergency. This is unprecedented, along with all the other unprecedented issues we're dealing with. But the fact that the houses of worship are shut down, this is truly unusual. It is only 1 week ago when the governor included places of worship in phase 1 of the reopening of Massachusetts. We, the members of this panel, when we heard that, we were shocked. As we will discuss, the science does not support the opening of places where large numbers of people gather in confined places for long periods of time. However, reopening is not only about science, but is also part of the intersection of political and constitutional considerations. And if just reading the paper last week, the Boston Globe discussed that very issue as to why the governor included houses or places of worship in the reopening of phase 1. If you choose to, you are now permitted to reopen with restrictions. Those restrictions can be vague, they can be incomplete, and they are certainly subject to interpretation. Yet they come with an enormous responsibility for synagogues to protect the health of the individuals who come to your congregation, to your synagogue, to your congregation as a whole, and also very important responsibilities to the general public of which we are all part of and responsible for. We trust and we hope that this presentation and discussion will help you carefully make decisions, provide resources, and help guide you through this very difficult and unknown time. If I could have the second slide, please, the next slide. As Gretchen had mentioned, these are our panelists. Just to point out that we come from both public health and medical backgrounds where they intersect, and yet we do different things, as Gretchen had mentioned. We hope we'll be able to provide you with a wide range of suggestions and challenges as we go through the discussion. Next slide, please. Our objectives during this process, is obvious. Well, there are a number of objectives. One, we want to discuss the knowns and the unknowns about the virus. What are these risks? What are we looking at? What the doctors are here to help answer those questions. We want to also discuss what the state is allowing and not allowing. What are your restrictions and other guidances that the state and others have provided and may be available to help you determine whether or not you open and how you open. We also want to identify and discuss strategies to decrease the risk of infections in places of worship and the spread of infection in the public realm, in your community. And finally, there will be, as Gretchen had mentioned, an opportunity for us to ask questions amongst ourselves, as well as for you, the attendees, to ask questions to us through the chat function. The next slide, please. So one basic question, why did the synagogues close? They did not close to protect the members of your congregation per se. Yes, they are interested in that. Nobody wants anyone to get sick. But the interest of the government was very clear, and that was one, to prevent public exposure to the spread of the virus. How can we, as the public, reduce the spread of this virus? And secondly, as we all know, is also to protect the medical system, make sure that it will function and function in a way that can help help the public as a whole in responding to the emergency as well as other medical needs. In other words, the medical system could not be overwhelmed during this time, and that's why the state exercised its powers to close synagogues as well as all the other closures that occurred, as well as sheltering in place. The next slide, please. And finally, this is the source. This is a hyperlink. It will be included in your resources to the the Massachusetts published standards and guidelines for places of worship. We will come back to that later on in this discussion. The next slide, please. Bruce, can you continue?
It's my pleasure. Thanks so much. So first, I do want to thank you all for coming this morning, and thanks for joining us. All my speaker notes and references will be available in the resource page after the presentation. We'll spend a fair amount of time on my first two slides, but do not be disheartened. After laying that groundwork, the presentation will move along pretty rapidly after that, leaving plenty of time for other presenters addressing your survey questions, panel discussion, additional Q&A before we're through. I've also invited my co-physician on this panel, Dr. Jonathan Slutzman, to freely interrupt with additions and comments and perspectives during the presentation itself if he would rather not hold on to those during the till the panel discussion. So getting to the meat of it, What makes our task today so hard? The evidence was clear we needed to close and approximately when. So now when it's not so clear what we should do, we're left with the decision-making of when and how we should open. Furthermore, there is insufficient data at this time to guide that decision-making. As a physician, I make decisions all the time with insufficient data. I apply the principles I've learned. I evaluate the risk of doing something versus doing something else versus doing nothing. The process of medical decision-making is very comparable to our task today. Be aware of what is known and be aware of what is unknown. Regarding the unknowns, be aware of what is suspected based on some but incomplete data and what is suspected based on prominent theories but almost no data. And be aware or make a judgment how likely those ideas are to be right, how likely are they to be wrong. Know your own goals, your own values, and the goals and values of your patient, or in our case, our community. Apply those values, weigh the risks, come up with a plan of action, but make sure that it is an action you can watch closely and based on the consequences, reassess and reverse or continue forward on the path you started. And perhaps as new data becomes available, change the course and direction entirely. Many organizations, including the Orthodox Union, the Reconstructionist Rabbinical Assembly, CCAR, Union for Reform Judaism, Conservative Rabbinical Assembly, Agudath Yisrael, and many others have put out statements which use classic Jewish principles to address the issue of how we decide to open our worship spaces. I suggest you read them all. Many of them are beautifully written. They'll be found in the resource area set up by the Synagogue Council at the conclusion of this presentation. They are a wealth of wisdom. But I believe our biggest source of tension in the conflict are between these two principles on your screen. One, kavod hatzibur, respecting the quality of life for the community. We accept that there is no zero risk scenario. Risk is inherent in our normal living. We are used to bad flu seasons when, because of our traditions, our clergy walk the aisles, shaking hands with everyone. We willingly shake hands with them, knowing this likely spreads flu, but accepting it as the way life works. From an individual health perspective, this might be unwise, perhaps deserves change. But these ingrained traditions, while somewhat unsafe, create a ritual framework which contributes to stabilizing our spiritual life. Regarding COVID-19, although we do not know for sure, we recognize that it is impossible to totally eliminate transmission. Further, it is likely, maybe even probable, that the same number of people will unfortunately fall ill and perhaps die, such that social and economic restrictions only change the timing, but not the total impact. Additionally, people suffer by limiting interaction through social loss, economic loss, spiritual loss. Therefore, kavod hatzibur would suggest we serve the most good by just enabling more public activity now. We hold this perspective in tension with pikuach nefesh, the primacy of protecting human life in the here and now because of our belief that every life and moment of life is precious. And this mandates we do everything in our power to prevent death and significant illness. We do not return till there's enough data to suggest that a resumption of prior activity is unlikely to cause additional loss of life. This requires waiting till greater society measures the results of the relaxation of restrictions, and the data comes in from the rest of society's behavior. After we know that for sure, we'll know better how to stay safe. We can apply the appropriate measures with very little guesswork. Furthermore, the assumption the same number of people will die could turn out to be incorrect. If research and medical advances go quicker than we expect, it is possible, maybe, that we would truly eliminate the total number of deaths if we delay. There is a middle-of-the-road strategy that blends these two principles. Allow the rest of society to loosen restrictions first. Observe what happens. The obvious large impact successes and failures, because of the time course of the spread of this virus, should be visible within 3 to 4 weeks. Then, based on what's observed at that time, decide what course to take temporarily. After 3 to 4 weeks, after observing more of society and the results of our own community's changed behavior, we're then in a position to make further changes while observing the effects of making those changes. When there's significant risk and when data is insufficient, this strategy of making social change 3 to 4 weeks behind the rest of society, when society is doing so experimentally, this strategy, slowly in increments with 3 to 4 weeks of observation before further substantial change, is the course I would recommend. However, if data is known or theories are strong with high degree of knowledge, one might act more boldly or cautiously as dictated by the data. Whatever your guiding values, we suggest your synagogues be transparent and clear in communication which of the competing principles they hold most dear, and strive to find the correct approach consistent with your own identity. Application of this strategy first requires we be clear about what is known securely, what has strong theoretical basis, though little real-world evidence, and what is little more than guesswork. So let's start with the science and what is known. We're going to move now to our first poll. I invite you to pick the answer which you think is most likely to be correct. And then we'll share our results so that we see what our community knowledge seems like, or our community guesswork, depending upon the security with which we all believe the data we're suggesting. We'll end the poll when it seems like entries have stopped coming in rapidly. I would think by now enough people have probably answered, though I can't see your results, so let's show the results. So you answered that the least effective was wearing gloves, that there seemed to be a high degree of confidence about wearing a mask. 18% thought that moving 8 feet away would be least effective, and 28% felt being in the room for 15 minutes instead of 30 would be least effective of a change. Okay, let's take a look at the science and see what it suggests. Next slide. As you look at this slide, you see a picture with a spreader in the upper left and 2 potential receivers of virus, one who is close, one who is far, one who is separated by a table surface. You also at the bottom see a list of similar kinds of diseases that our public health folks have had to deal with in the past, and a chart which shows their relative size compared with the smaller size of COVID-19. Because of our experience with other illnesses, the physics of respiratory droplet spread is relatively well known when those droplets are large. But it becomes quite complex with COVID-19, and there's not sufficient time to go through it all. But here are the highlights. We know the risk of significant spread by person to person is primarily affected by the activity of the spreader, the distance, the time, and the number of people in a confined space. There is mounting but not conclusive evidence that the number of virus particles one is exposed to not only affects the likelihood of disease, but also the severity of disease. As with other viruses, at short distances, the high risk is large droplets loaded with lots of virus, primarily transmitted through coughs, sneezes, and unavoidable spitting while talking or eating. At very close distances, you can get a few of those droplets from breathing as well. Because they're heavy, these particles settle to the ground and other surfaces quickly, as long as air movement is not too strong. In a strong breeze or wind, they could travel further. Risk decreases rapidly at the cube of distance, meaning whatever your risk is at 4 feet, it is 87.5% less at 6 feet. And whatever your risk is at 6 feet, it's 70% less than that at 8 feet. Distance helps a huge degree, but the risk never falls to zero. If worn properly, masks can markedly filter out spread of large droplets. It prevents spreading virus to others much better than protecting the wearer, but both are significant. This is known. A poor-fitting mask protects substantially less well. A mask worn over the mouth but not the nose accomplishes close to nothing. All of this is known due to our years of experience with those other similar viruses. But the different important characteristic that COVID-19 is smaller raises the possibility and strong likelihood that it can therefore be carried more easily on small particles, which can remain suspended in the air for longer and travel further. This important difference was not recognized at first. Together with other information, we initially came to the conclusion that if people got infected and were not close together at the moment, the infection must have come from surface touch. We're now beginning to appreciate that small droplet spread may play a more important role at a distance, and surface touch may play a less important role than we initially thought. Certainly, both play a role, but what deserves the most attention and concern is still somewhat unclear. Small droplets are carried in large numbers during shouting, heavy exercise breathing, and especially during singing. Wind and ventilation can markedly affect distance. Efficacy of masks is uncertain for small droplet spread. Small droplets can accumulate in the air over time because they do not settle quickly. So the longer one is in a small droplet environment, the more one's risks increase. The quantity of risk caused by small droplet spread is less well understood, but there's enough reports of extremely prolific spread and those receiving the virus having statistically more severe diseases that in situations in which singing occurs, we know we need to be far more cautious, particularly if that singing occurs in a closed space. Despite social distance, it is probably dangerous to be in a room with singing for any more than an extremely short period of time if that room contains anyone with COVID-19 who is singing. But at the current time, no one knows how short a short time is. For these activities where particle movement is controlled by variable slight small airflow patterns, plexiglass barriers probably offer little protection, if any. Theoretically, flushing a toilet can create small droplet virus spread, but there's no solid real-world evidence either way for or against that this is a significant source of spread. So to summarize small droplets, what's still unknown, much is still unknown, except they travel further, they hang around longer, and masks protect less well. Calculating exact risks regarding time is not well known, but it's believed to be important. There is no distance or time or minimum number in a room that's absolutely safe. But if not singing and being greater than 6 feet and spending less than 15 minutes with someone with COVID-19, that situation reduces the risk to a level which the CDC considers acceptable. That means if you're wearing a mask, are greater than 6 feet, spent less than 15 minutes together with the known COVID-19 contact, and no singing was involved, even if the person next to you was found to have COVID-19, it is highly unlikely that the health department would ask you to quarantine yourself. There's no accepted formula available to help calculate the risk contributions of activity, distance, time, numbers, the inevitable air movement that occurs just because we're occupying the space. With high confidence, we know that absorption of virus through the skin is almost non-existent. One could touch any surface safely without skin protection if you knew 100% that you would not transfer that touch to your face or someone else's face. Unfortunately, we touch our faces all the time. We touch our faces more if we adjust our masks. Viruses need moisture to survive. Once evaporation is complete, we believe surfaces now are fairly safe. Accordingly, you add safety somewhat by not sharing ritual objects which could retain moisture for a short period of time. But distance, numbers in the room, and time are far more important than sharing objects. Regarding COVID-19, allowing adequate time for moisture to disappear from objects is probably as good as actually disinfecting them. Doing both is even better. Bathroom sink knobs and door handles and metal objects and smooth plastic tends to allow moisture to remain for longer periods and transmit that moisture more easily, and in theory are higher risk objects for spread. In practice, there's very little evidence to either confirm or refute this. The risk of a group of people getting virus also largely depends on the risk that any one of them has it. The evidence is strong that the highest risk of spread is one day before a person knows they are sick, and they usually do not have a fever at that time. Once they know they are sick, they're usually staying home. If they didn't stay home, their risk of spread would be quite high, but in general, we are not encountering those people. We are encountering many, many people who are one day before they get sick. You see report after report in the news regarding large outbreaks due to one person, and some quote like, "But he had no evidence he was sick at the time." That is not an exception. That is the most likely circumstance for spread, and our synagogues will face that circumstance repeatedly. We are now also seeing emerging reports of super spreader events. Why numbers seem to matter is not well understood. Large numbers seem to create super spreader events where the number of people infected and the severity of disease seems to be out of proportion to what would otherwise be expected due to the principles of distance and time. One can theorize why, but really it's not well understood. This suggests that paying strong attention to the total numbers in a confined space, no matter how big the space is, may turn out to be more important than just using a density measure like the state guidelines of 40% capacity. The point is, you can be more restrictive than the minimum state guidelines, and we're giving you the science to support that that makes sense by creating longer distances, shorter times, and keeping the numbers in a room down. Let's move on to the next slide. So the main points are really on this slide itself. The main thing we need to do, assuming an environment in which there isn't much singing or very heavy breathing, is stay away from people from within 6 feet. The respiratory droplets can spread long distances when singing. When there's an infected person who coughs or sneezes or talks, that's where you're going to have the largest risk in short periods of time. Droplets land in mouths or noses of people nearby, and droplets can come in contact with surfaces. And when people have in contact with those surfaces and then transmit to their faces, that can spread disease. But most importantly, disease may be spread by people who are not showing symptoms. I just got a chat question. Do we know how much spread is due to people who never show symptoms as opposed to people one day before they start having symptoms? The answer is no, we don't. Next slide. So, excuse me, I'm having a slight technical issue with my notes. We'll get there. I want to go over the risk of transmission based on age. Young people are believed to have the highest risk of transmission, but the lowest risk of illness, lowest risk of death. Older members, based on their activities, have the highest risk of severe illness and death, but lowest risk of transmission unless they're coughing at the time. This may suggest, and the data is not clear, but this may suggest there's good reason to consider segregating children from the rest of the community when in the building, particularly if those children are young enough that they can't control their ability to keep their masks on well, to keep their hands away from their face, to touch other objects that people will inevitably be touching soon. At this point, the state requirements do not permit childcare. While the risk of severe illness does increase with age across all ages, when this started, based on the original reports, we thought that risk markedly rose with age above 60. In the US, this seems to not be true, and age 65 seems to be the break point when there's a noteworthy increase in risk of severe illness. At around age 80, that risk rises very steeply. At all ages, ad mea ve'esrim, until 120, you're still more likely to recover than die. But the closer you are to that 120, the closer to 50% that risk becomes. Those with underlying conditions, immunocompromised, diabetes, asthma, COPD, a bunch of other conditions, are also more vulnerable to disease. And as I think we all recognize at this point, there's no vaccine, there's no treatment, there's no known immunity. And antibody testing in its current state is not reliable enough to be used to make any sort of reasonable decisions. Next slide. So here we are. We have risks. In this presentation, we are stressing that risk is unavoidable and knowledge is rapidly changing. Some people are worried about different kinds of risk. This suggests that better decision-making for any particular social group depends on input from many different people who are clear about what risks they specifically are most concerned about. Accordingly, synagogues with advisory committees are more likely to manage the decisions in a way that addresses the concerns of its constituents. The different kinds of risk that are commonly discussed and have differing impacts on planning include how worried you are about exposure to the virus versus getting infected with the virus, versus getting sick with the virus, versus spreading virus to others in our synagogues, versus spreading virus to the larger community, versus spreading virus to vulnerable people, and then especially more of us would be concerned of the low risks in most age groups of prolonged severe illness and especially low risk of death. However, as we said, the risks for this virus are higher than most of the viruses we have been used to. There's another form of risk, synagogue legal liability. Regarding legal liability, I do not want to overemphasize or underemphasize this. While someone can attempt to sue you for anything, you create a substantial defense to a successful case if you follow carefully the state guidelines as published and you consult with your local board of health regarding any questions or clarifications. If local responses are not clear, then consider consulting with your synagogue attorney. Absolutely do not claim something is safe when you cannot make that claim. If you do not follow the state guidelines, you additionally run the risk of the health department shutting you down for endangering the community. Traditionally, health departments have been reluctant to treat houses of worship strictly, but as Ethan pointed out already, there's little precedent for a virus that impacts this community so substantially. We now move to the next slide. And so the bottom line is, the more we are together, the more we risk exposure. All models show that if we have no social constraints, risk of exposure will increase over time. With the help of Paul Bleicher, a physician researcher in Newton, and based on the well-accepted Yu-Yang-Gu model, which predicts what happens with social constraints, I ran some numbers for Massachusetts together with Paul. Most likely, between 0.6 and 2.7% of the population in Massachusetts is infected and capable of spread at the current moment. Probably 25 to 50% of them do not know it yet. We are not secure in our numbers because we haven't done enough testing to know. This potential for spread is high enough that it's prudent to assume that every congregant is capable of spreading virus. In addition, our communities are not random. Risk for urban communities will be higher. If a larger number of congregants interact with many people, risks for that congregation will be higher. This helps us understand the relative magnitude of the risk, but it's not really useful for confident decision-making. And we recognize this can change at any moment. Since there is up to a 2.7% risk that any random congregant is capable of spreading virus, and that in many synagogues the demographics are such that the risk may be even higher, many people would consider the risk of spread in a single short minyan too high right now. And the more frequently the congregation holds events, the more likely spread will occur. However, the Yu-Yang-Gu model does suggest that if there are social constraints, risk will be decreasing in the future by approximately 1.5% per month over the next number of months. As time goes on, we'll be gathering better information and our models will become more accurate. This is only one factor that might enable us to have enough information by mid-August to decide if meeting for high holidays in large numbers is too great a risk or not. Right now, we just don't have enough information to advise regarding the safety of this. We'll be addressing high holidays again later in this presentation. It might be wise now to create a multiple contingency plan for a wide range of possibilities for high holidays, and these plans should include the possibility of having another shutdown. All of this, of course, can change significantly at any moment. Bottom line, we still need this philosophy that any congregant can be a risk. And I'll hand it over to Wendy.
All right, thank you, Bruce. Well, you've really laid the groundwork here, thank you. And I'm gonna go very quickly, I think, through some of these basic elements just to reinforce what you've said so that we're real clear on sort of the basic, on the principles. So if we assume that all congregants are infectious, right? These are folks, these are us. We are asymptomatic, particularly moving into this phase 1 of the governor's plan where things are opening up. And our goal here are this assumption that we're all infectious is I think, a very reasonable place to start. So how do we decrease exposure to ourselves and to others? We need to remember that we lack the testing data to assume otherwise. If we were clear that we were not symptomatic, we could make other decisions. Now, how do we decrease the risk of exposure to infectious person? That's our objective. And from that perspective, let's now think about the factors that influence the potential for the virus to spread from the infectious person and perhaps an asymptomatic person to others. Next slide, please. So this slide is simply a diagram identifying the things that we can control or begin to control to decrease exposure to the virus. We can't control everything. And as Bruce mentioned, risk is not zero. And we have to remember that the virus is transmitted by particles, fine particles, aerosolized particles in the air, person to person. So in summary, the key risks in our control include the numbers of people gathered, the proximity, and this is a continuum, as is the numbers of people. No distance is totally safe, and handling and touching shared objects and surfaces, and then touching the face is a consideration. We also need to consider time, as you very correctly identified in the poll when we first began. So these criteria or these factors, numbers of people, distance, and time will be key to understanding and developing a plan for moving forward. Next slide, please. So again, with the diagrams, I guess I like triangles, I don't know. But this is a diagram that we often use in the world of environmental health when we seek to think about what are possible controls. They're called hierarchy of controls. Which of those things work best to decrease exposure to the agent of concern? And in our case, it's the virus. Nope, previous slide there, thank you. And these are commonly used, but essentially the same principles. Top of the triangle is the most effective, right? For just getting rid of or to prevent exposure, we stayed home. And that was pretty effective in decreasing the number of cases, starting to decrease the number of cases. And as we move down this triangle, we go from the most effective to the least effective. And you see the masks at the least effective. As Bruce pointed out, keeping a mask on, even if the mask is on properly, is somewhat effective. But when it starts to hang off, or our noses are uncovered, or our mouths are uncovered, or there are gaping holes, that it becomes least effective. And in between are the substitutions, like only leaving home for essentials like groceries. We're talking about here, how are we going to begin to gather? Where would we put gathering as essential? And then we move into the engineering controls, hand washing, surface cleaning, and third, in including surface disinfection that we'll talk about, and ventilation, and then again to the masks. Again, our objective here is to decrease exposure to the virus. If we prevent or decrease exposure to the virus, we will have fewer numbers of people infected, we will have fewer cases, we will have fewer severe responses, and fewer deaths. Next slide, please. So let's talk a little bit about masks. Our recommendations is that masks should be required. And this is why. The masks, as Bruce mentioned, there's fairly good science that they reduce spread. There's good science to recommend them. And of course, the governor requires them under certain conditions. We should also recognize that there are people who cannot wear masks for medical or other reasons. And so that brings us back to how are we going to gather as safely as possible. Regarding gloves, our recommendation is do not require them. Why? There's good science that they're useful in food and medical industries when changed frequently between uses and hand washing between. Very questionable when worn for other activities or without frequent hand washing. Our recommendation is to not require them except for food preparation under certain circumstances and distribution when handing out certain items. But you're not permitted to have social food consumption now under the governor's order regardless. Regarding temperature screening, our recommendation is not to do it on site, and this is why. We now know that most asymptomatic or pre-symptomatic spreaders may not have a fever. Some will. Temperature screening only gets a minority of those who are pre-symptomatic. And it can create a false sense of security, as can wearing gloves. Regarding the temperature taking, it's expensive and requires mask removal and not recommended on site. But you might consider encouraging voluntary temperature screening at home by attendees when you go that route. And if their temperature is above 100 degrees, encourage them to stay home and contact their own healthcare provider. Next slide, please. Social or physical distancing. We've seen this term move from social to physical distancing. And so we already talked about the fact that as the distance increases, certainly the potential for exposure to the aerosolized virus, the particles also increase, that decreases. So decreasing the risk of aerosolized droplets containing the virus moving from one person to another. Distances can and should be longer than 6 feet. This is 6 feet in all directions, not just side to side. So you'll have to think about your seating or your standing, front to back and side to side. Next slide, please. So cleaning and disinfection. First of all, cleaning is the term we use, and products are used to remove dirt or schmutz, right? This is not the same as disinfection. Disinfection is to kill microbial organisms, including viruses. And disinfection needs to be done properly. There needs to be time with which the disinfectant is applied to the surface, and it can actually start to break down the microbial agent. That's called the contact time. And there's some question about frequency. For surfaces that are high contact surfaces, you'll want to do that much more frequently, door handles, etc. Now, there are a couple of points to make. One is that you should be using disinfectants that are certified as disinfectants. It's the Environmental Protection Agency that registers disinfectants. And you'll need to see on the label, and you must read the label at all times. The label tells you whether this material will disinfect emerging viral pathogens. Products that state human coronavirus claims have not actually been tested for human coronavirus, but they may have been tested or meet the criteria for emerging viral pathogens. So you're looking for the terms emerging viral pathogen disinfectant. Again, read the label. We'll provide information as a resource. You should always use these chemicals safely. They are hazardous. We never mix bleach, sodium hypochlorite, and ammonia because we will cause very bad health effects in people using them. We want to make sure we use them in ventilated spaces. And these are to be used on surfaces, not on humans. Okay, next slide, please. So, ventilation. This is one piece of the equation. And it's becoming more and more apparent that there are a variety of recommendations that are being made. Our recommendation is that you must know your system. You must know what kind of ventilation system you have. You need to know what your HVAC mechanics look like. What we seek is that we have adequate ventilation to filter the air or to remove, dilute the air such that we are not causing an accumulation of particles indoors. One thing that's extremely important though is that if your system has been shut down or reduced in use for a while since the buildings have been closed, is that there is a potential for standing water where mold and other hazardous substances, microbes can grow, including Legionella, which can result in a type of pneumonia and can be extremely problematic. So again, I'm going to leave it at this. We'll talk about this probably in Q&A, but you need to know your system. That's extremely important. And it isn't just important for COVID-19, it's also important for you to understand how to increase the air quality in your buildings. Okay, next slide, please, is a poll. And we're asking this: does a window air conditioner introduce fresh or outside air into a room or building? Yes or no? This is to get you to think about what your buildings look like in terms of ventilation. And then I'm going to turn this over to Ethan Mascoop, who will take us from there.
Thank you, Wendy. And we'll give another half minute for the poll or less. Okay, I think probably most people could answer yes or no at this point. Can we see the poll results? We're pretty much split. A little bit more on the no side. The answer is no. Some air conditioners have a button that you might be able to get some outside air, but that's not the purpose of the air conditioner in the window. It's to recirculate the air and to remove the heat from the inside to the outside. It's a heat exchange. But the reason for the question, as Wendy had mentioned, is that it's important to understand your system. This is just one of many kinds of systems. And also many buildings, many synagogues might have a hybrid of systems. For example, the school wing, maybe buildings were built over a period of time. So a school wing might have one kind of system, the sanctuary might have a second kind, and the offices might have a third. So the emphasis here again is understand and know your system, who's maintaining it, who's responsible for it, do they understand how it works and what it's designed to do. Okay, let's move on to the next slide, please. Next slide, please. Okay, we introduced this same slide earlier. This is your source of information for what you need to do. when you're looking, and also recommended from the Commonwealth of Massachusetts. I'm still seeing the slide of the poll results, if that could be removed. Or maybe I can remove it. Okay, thank you. Okay, next slide, please. Okay, here's another poll. Massachusetts requires a permit for which of the following? Do you have to go to the town hall or your city hall for the permit to reopen the place of worship, to put up a tent, to review and approve your written plan for seating, or your security plan for your place of worship? Which one of these requires a permit? Okay, do we have the results? Yes, great. Okay, putting up a tent in which to worship. That is the correct answer. I'm not sure if there's a prize at the end, but thank you very much. That's good. Let's move on to the next slide. Okay, so I wanted to point out some of the mandatory standards that the state is requiring if you choose to open. One is 40% of space maximum occupancy. This is a very, very important number. People want numbers. I would want to emphasize that this number does not come from science. This is a number that it's a best guess or an estimate that the governors and the governor's advisory committee has established. By the way, all these rules we're talking about are for Massachusetts only. They do not apply to New York, Rhode Island, New Hampshire, other places that are represented in the webinar. And the reason for that is health and health concerns and boards of health and health departments and all of that realm, those are controlled or those are ruled by state oversight and responsibility. It does not come from the federal government. It comes from the local and state governments. So in other words, you hear quite often, CDC has recommendations. They are recommendations, they are not orders. The orders and the requirements come from the state and also your local government. So 40% is what they've chosen. They've determined as the maximum number of occupancy. How do you determine that occupancy? The occupancy loads should be posted, the certifications should be posted inside your building, in those places of gathering. Quite often, those postings have been removed when you've been painting, making renovations, but they should be posted. Regardless, if you don't know what your occupancy level is, you should go to your town hall or city hall, ask the Board of Health. They might consult also with the building department, and they will get back to you with a number. All rooms that hold 50 or fewer individuals do not require a posting, but they also have to be calculated in with that 40%. When you calculate the 40% as well, it includes all the attendees, and any staff and any clergy are in there. So in other words, all the people that are in the building at that time is included in that 40%. Childcare is prohibited. Also, face coverings. I want to go to number 3 for a moment. Face coverings, they are required, but the regulations state, or the standard state, that it's in compliance with the governor's order number 31, which I'm sure you all know of by heart. But that will be posted on the website, the Synagogue Council website, as to what the order is. Essentially, it is, if you can't maintain 6 feet of separation within a confined space, you have to wear a face covering. We're recommending that you should wear face coverings regardless of the distance or separation, but the standard as set by the state is the 6 feet or the 6 foot standard. Finally, I'd like to emphasize number 8. The regulations or the mandate by the mandatory requirements is that the Board of Health, the synagogue or the place of worship must cooperate with the Board of Health with contact tracing if a COVID-19 positive individual has been in attendance in your building. It also states you must cooperate with the Board of Health with reasonable requests. Now, by the way, if you were any other kind of entity in Massachusetts, they would require cooperation, and they require certain things such as mandating a list of those who come into, let's say, the barbershop or the hair salon. And then you are required to turn over that list to the local Board of Health or the state health department. For synagogues and for places of worship, the wording is slightly different, but they encourage you and they require you to cooperate. And that, however, is, again, it's a tension point, because some people, you all know, I'm sure you're all aware, that again, the issue of right for privacy, right for free worship, all of those issues can be in tension with this cooperation. However, the government is saying that if we allow you to open, there's a partnership, because we know this is a risky operation. This is a risky procedure of gathering people, large groups of people, confined space, and there will be a risk. There is a risk, and there is a likelihood that there will be someone who will attend with COVID-19, and they need to track that person. They need to trace that person, also the contacts. The likelihood is, if that happens, it's possible and very likely that all the attendees at that event or that service might be ordered to either go into, well, ordered to go into quarantine. It might effectively shut down your operation or your synagogue as well during those few weeks of quarantining, depending on who attends that program. This is a very, very important part, but without that ability to contact trace, then the entire system falls apart. As you read through, if you read the regular press, everything, not everything, but a lot of this is based upon, this is a key part of trying to control the spread of illness and COVID-19 within the community at large. That's why it's there. One more thing I want to mention about the mandatory standards, as you've heard Wendy and Bruce mention, time is important. These standards do not address time. That is up to you as a synagogue to determine time. How do you reduce the amount of time that people gather together? And we can talk about that later, but I would like to raise the point that time is not considered here. Next slide, please. As I mentioned, the recommended online sign up for services, or how do you monitor who's coming and limit the number of attendees, placing tape, all these other ideas, promote ventilation. Within our panel, we've had a number of discussions about opening windows and doors. Sometimes that's good. Sometimes that might not be appropriate depending on what kind of ventilation system you have. It comes back to knowing what kind of ventilation system you have and what are the appropriate approaches to encouraging or introducing enough fresh air and airflow and dilution within the space. These are things we're seeing when you go shopping as well in the supermarket, keeping people separated, monitoring people when they come and go. Those are the same kind of things the state is recommending in a house of worship. Next slide, please. Synagogue responsibilities from this is, one is, again, enabling efficient contact tracing. I cannot emphasize that enough. The state, that is why I would suggest the state is allowing synagogues and houses of worship to reopen, because they are counting on the fact that the synagogue and the other houses of worship will be effective, will be a good partner with the local government in terms of, in the event that an individual with COVID-19 attends your program or your worship service, and will they then, they need your cooperation. Otherwise, again, this does not work. Next slide, please. Our recommendations, I think we mentioned that a bit with Bruce. Again, create an advisory committee. I'm sure most of the synagogues have done that. Recommend transparent and frequent communication with your congregation. We recommend record keeping, who attends, maintenance of interventions, who's using chemicals, when do you monitor, when do the ventilation system, your HVAC system's been maintained and serviced. Security. We've gotten a lot of comments that this is all in conflict with security in terms of wearing masks, identification of people, entry and exit from the buildings. But we recommend that being transparent and open with your community, as well as on your website. If I, as a member of the community, want to go to a particular synagogue, I'm very likely to go online, look up your synagogue, and if I see that there is a plan in place, if I see you've addressed these concerns, if I see that you've even considered what kind of ventilation systems you have and how you are handling that, I would feel much more comfortable attending your synagogue than if I don't see any mention of this at all. And that would inform my decision, or help me make a decision as to whether or not I would attend or recommend other people attending your synagogue. Next slide, please. So the considerations are, we ask you to plan for a range of possibilities, that as we move forward, for example, if a COVID-19 person who's positive comes to your synagogue, you might be closed for the next 2 weeks, not because the government is closing it, but because everyone's in quarantine. And also, we want to plan for imperfect compliance or adherence from the folks that come to your service. It may not, people are going to handle their masks, for example, and it's not possible. Our recommendation is not possible to really police that. However, going back to masks or face coverings, the guidelines give you the option or give you the authority to refuse entrance to an individual who says, no, I will not wear a face covering. But if a person says, I will not wear a face covering because I have a medical reason or other reason or psychological reason, you cannot ask for evidence or for documentation that they have that disability, and they do not need to wear a mask. For this, I think the next slide, please. Bruce, this is for you, okay?
Actually, it's for Jonathan.
I'm sorry, my mistake. Jonathan, if you're
That's
there.
all right. Thank you, Ethan. All right,
Okay,
so
you have a poll.
a couple of final polls here, and I recognize the hour, so I'm gonna breeze through as quickly as I can, recognizing also with your indulgence that I worked last night. So you started to make some plans. What considerations might guide your plans for further relaxation of interventions? And one option, you can open now. You can expand your in-person activities when the risk of COVID is no more than double a bad flu season, when it's the same as a bad flu season, when it's less than a bad flu season, or I honestly just don't know. And then thinking of that question, although your answer doesn't have to be based on what you answered in that question, how much information do you need to make your own determination? Do you have to have data that are known to the best of our abilities and published by an authority such as the Centers for Disease Control? It has to be demonstrated by good science, so maybe not to the level of a government imprimatur. Does it have to be believed most likely by trusted medical and public health authorities, or some other answer? So answer those two questions, and then we'll move on to the closing couple of statements. All right, I hope folks have been answering. I can't see.
Okay.
All right, so great. A good chunk of answers here that we just don't know, and I think that's entirely fair that our participants here and the leaders of our synagogues are in a position where there's a lot of uncertainty here, and we don't know what the appropriate level of risk is. As Bruce said at the very beginning, some of us are very used to making decisions in limited information environments where we have to balance risk against benefit, and it's very challenging. It's very challenging. And then the question is, how much knowledge do we need to know? How much certainty do we have to have? And it seems that the majority of people would be comfortable with believed most likely by our trusted medical and public health authorities. Of course, then we have the question of who is a trusted and well-known public health authority. So let's go to the next slide. And then the slide after that is going to be poll 5. And the slide, there we go, some final notes here. And the key is that the science is not entirely certain. This is a disease that is pretty darn new. And we have learned a lot in the last few months, faster than I suspect we've learned about most of the diseases that we face on a regular basis. There's some information that we suspect, there's some we know, there's a lot that we don't know. The line that some folks have used is that we're building the plane as we're flying it, and that's simply the case because we don't have a choice. We have to do our best with the information we have, however limited it is, just as Bruce and I do on a regular basis with our patients. That's what we have to do as community leaders. At a very minimum, we should be following state standards, but I hope that in the last hour, you've taken away that at least our recommendation from the four of us, having looked at the evidence and the data and the case reports, is that the state minima when it comes to at least synagogue worship are not likely sufficient to protect public health to the degree that we would feel comfortable. We should all think about our core missions and responsibilities, develop a plan addressing your values. I think that this is not a case where we're thinking an either or. Either we meet in person or we do not. Rather, we should be focused on thinking, how can we best serve the spiritual, religious, and communal needs of our people in new ways, in better ways, so that our folks don't necessarily feel as much loss, or perhaps even any loss, from not being able to gather in person. And then certainly we have to share our knowledge and resources and act communally. Next slide, please. A few weeks ago, Dr. Anthony Fauci, who I'm sure you've all seen, he's the director of the NIAID. He's referred to as the nation's chief infectious disease specialist. He had an interview with the Orthodox Union and answered a question about holding services on the high holidays. And the key is, in his statement, what I'd like to highlight is that it's entirely dependent on reliable testing and good contact tracing and isolation. The idea being that we need to be able to, for lack of a better term, pounce on any small outbreak of disease so that we can draw circles around those people to prevent further spread. And that requires good contact tracing and reliable testing. In his opinion, and we think that it is fairly reasonable and likely accurate, that it's unlikely by mid-July that we would know that those standards have been met such that we can meet in person for any semblance of high holiday gathering. But hopefully by mid-August, we would know if those standards have been met with low community spread and available testing and effective contact tracing. Next slide for our conclusion. There are some resources. You can certainly go to the Synagogue Council page. I've done my best to try and answer at least some of the questions that have been posed in the Q&A at the bottom of your screen. If you have further questions, you can certainly ask them there, and we'll do our best in the limited time we have available. And certainly you can follow up with questions directed to our group. We're all willing and able to take offline questions as well. So with that, we'll close the formal presentation.
Thank you very much, Jonathan, and the rest of the panelists. Gretchen, do you have any questions that you've seen that you'd like to ask the panelists?
So in the second phase of our program, we've called questions from those submitted by our participants in their registration forms and surveys. And they'll be answered by our panelists as a panel, as opposed to individual presentations. The first few questions deal with vaccines. Without a vaccine, will conditions be different in a month or two? Is there a possibility now to plan for several months or a year ahead? I would like to take that question.
This is Bruce. I think Jonathan's answered that question, that without a vaccine, if we continue social constraints, if the government successfully puts in place good contact tracing, then we will know the answer to that question. If the government does not successfully put in place good contact tracing and good testing, we cannot answer that question.
I would add to that, Bruce, is that that part of the government doing good contact tracing depends on the synagogues doing good cooperation with the government in terms of contact tracing. For example, if the COVID-19 person who's positive goes to a synagogue event. So it's a partnership here.
If we know that there are anti-vaxxers in our community, even if there is a vaccine, can we rely on herd immunity?
So I will start that right now. We do not have herd immunity. We will not have herd immunity for quite some time. I'll let the MDs speak to the percent or the numbers. We need, I think the evidence is something like 70% minimum people who have effective antibodies to the virus. And the outstanding question remains whether getting the disease once actually gives you immunity. That's still a question. And so in terms of anti-vaxxers, this is a challenge. This is a huge challenge in the public health world. And right now, what we're trying to do is to try and understand whether sort of what the numbers are. And I'm going to turn that over to others who may wish to speak about that. But again, we don't know yet.
I'll just toss in that we have to remember that there are many more things we don't know and probably won't know for a while. Even if a vaccine is created, what percentage of people will respond well to it? How long will it last in terms of immunity? So the answer that Wendy gave is essentially correct for many, many reasons. We just cannot know.
What if the elderly or immunocompromised people would like to come anyway?
I'll address that. There are two facets to how people have asked this question in their initial surveys. One was, could they meet by themselves? And it's the same principles that we apply to a community. Their risk is higher, but if they've talked with themselves about what their risk and tolerance is, what they're willing to do for their quality of life, prudence would suggest we apply the same principles, but more strongly. They meet for shorter periods of time at larger distances, and with less frequency, that would be safer. But it's their choice to the degree they want to take the risks. In terms of whether we allow them to take those risks in our community, well, that's a matter that each individual community has to decide in its identity. How paternalistic does it want to be regarding those who see the quality of the risk worthwhile? I would say our responsibility is to make sure we have educated them that they're engaging in a very high risk activity. Their risk of spread to us is probably low in comparison with our risk of healthy people spreading to us.
And again, if I may, that also would be perfectly legal. In other words, if you have a gathering of high-risk individuals in a synagogue, if it's fewer than the 40% occupancy load, as far as the state's concerned, that is fine. But this is your responsibility to decide what risk you're willing to take.
So attached to that question, what if a vulnerable group wishes to form its own smaller Minyanim services?
Yeah, I surprised you by answering that question in advance. I think we're good with that question.
I would also add as well, if it's 10 or fewer people, according to the state, if it's outside of a house of worship, those standards still hold across the state.
So there were several questions about convening services or gatherings outside, or spontaneously home events, or families gathering together in small units, aside from short period of time and maintaining small numbers. Do you have any other guidance?
I do have 3 points that I think the synagogue should be aware of. One is, if they are condoning those as synagogue events in people's homes, they have taken on responsibility that the state standards will be met. The second is, if individuals choose to do it outside of synagogue, or even if synagogues do take the risk by condoning them in families and homes, our natural behavior is we will probably be less careful, less good at maintaining distance, less good at keeping time short. The risks will probably, just based on social behavior, be higher.
It will also be harder to contact trace.
That's
because you
right.
don't know who's coming and going.
That's
and
right.
everything depends, as we've
On
heard
food
before, everything depends on that as well.
Right.
The governor has instituted a phased approach to reopening the state. Can you imagine a phased approach to reopening synagogues? And if so, what would that look like?
I'm believing we already answered that in the presentation. You look at what the rest of the communities have done first. You then see if it seems to be safe for them. You then slowly follow that lead if it's working safely. You don't if it's not working safely, but you make small changes. You wait 3 to 4 weeks to see if you've created an unexpected risk. And in slow increments, you creep back to normal.
There was also a question about meeting outside. Does air movement and or breezes increase risk?
Wendy?
The question is if we meet outside. So the issue is let me just get this straight. This is not about the actual people meeting together, but the breeze blowing, right? So
together and
okay, so the together part Bruce has already addressed. The air part, the airflow, right, is probably increased, right? If you've got the wind blowing, but you still need to maintain the distances, you still need to be very judicious about time and about mask wearing. It doesn't remove those other things, and it's very easy to be in closer contact when you think everything's fine outdoors. Let's look at the governor's order and communities, local boards of health, who have instituted their own mask wearing requirements, even for outside. Those are done, it's outside. So, you know, we should not have an issue, but we do, right? So it's about these layers of strategies that are needed to decrease that exposure to virus.
Bruce, did you want to add something to that?
I agree with everything that Wendy said. Maybe to help picture it is that if you happen to be unlucky and have a strong breeze moving in a certain direction at the moment that somebody sings or coughs, that breeze in a particular direction is more likely to cause spread much further than 6 feet. If, on the other hand, it's a still day, the fact that you're in a non-confined space allows the particles to distribute over a much wider space, meaning that it's a low concentration and you're far at much less risk than if you had been in a confined space. And you can't predict the airflow issues well enough to know whether you're going to increase or decrease your risk.
We also don't know how much virus is required for infection, right? I mean, so that's another piece of the equation.
Right. So I really can't advise you, other than to say it's obvious, do not be downstream from a breeze if you're doing outdoor meeting. And other than that, I don't know how to answer the question. It's too complex.
I'll add that essentially what we're trying to do here is extrapolate from limited data. And the limited data we have are not based on people gathering for a singing event in an outdoor venue. They're extrapolated based on individual epidemiologic tracing to identify where some subset of people have become infected. And the vast, vast, vast majority of infections have happened inside buildings, so in some sort of enclosed space, whether it's a healthcare facility in the case of nursing facilities, or community spread is most easily pictured in a household setting with household contacts. So we just don't know. We can say that there is limited risk when people are outside, but that is based entirely on the statement that there haven't been that many people infected outside, but there also haven't been people gathering for singing worship services outside.
However,
oh, go ahead, Ethan.
I was just going to say, but historically too, we have some anecdotal data from the Spanish flu when Philadelphia held the parade and Kansas City canceled the events, and then Philadelphia saw an increase of cases. Of course, we don't have the kind of data gathering that we have today, but at least historically, we have something that informs us that large groups of people, even outdoors, is a greater risk than not.
And I think what we're going to see is as the data, as we get more data with things opening up, we'll be able to answer some of these questions with a little bit more data, maybe a little bit less extrapolation, but we're not there.
There are a number of questions related to masks. For example, full face shields versus masks. Recommendation?
This is so interesting because we grappled with masks back in January and February. Should we be recommending? What are the data? What are the data? Who do they protect, right? And so we are now grasping at that mask as if it is sort of the last, it's the end of the triangle that I showed, right? And so, we're trying to figure out how we can use this to really prevent exposure. But they're not efficient. I've seen estimates of 30% to 40%, maybe under conditions when they're worn well. We see that with face masks, face shields, people are also wearing masks, right? So it's mask and face shield because the face shield, right, it's not closing off the breathing zone. Maybe, I'm sure Jonathan can address this better than I, but that's what we've been seeing.
Yeah, I can answer that. The environmental fluid dynamics of a face shield versus a mask are greatly different, and air, particularly with high airflows that are used in loud speaking and singing, would almost certainly skirt around a face shield the same way that they would try and skirt around the seal of a mask. And I can say that in high-risk environments, in healthcare facilities, we are absolutely not relying on face shields alone. In fact, we use masks plus face shields so that we can cover even more protectively. So my recommendation, and I don't know if Bruce can add to it, is that a clear face shield would not be equivalent to some sort of filtering mask.
Yes, absolutely, I agree. I think the stronger question is, should we wear a face shield in addition? And the place where face shields become useful is you have no choice but to be at a close talking distance where someone might be in their talking or eating or speaking, accidentally spitting during the conversation. You're at 4 feet or less. You have no choice but to be in that interaction. That's when a face shield is going to be useful. Other than that, I probably wouldn't bother.
So
I agree.
Not safer to sing with a mask?
Excuse me?
Properly masked, it's not safe to sing?
No. Based on case reports. It's not strong science yet, but there's enough case reports out there accumulating that it would terrify me, and it takes a lot to terrify me.
I agree. Yep.
Chevre, in the interest of time, especially respecting that of our panelists who are very busy medical practices now, we could go on with this all day, but we're going to call a close to today's workshop. I'm David Burnett, the Executive Director of Synagogue Council, and I'm going to conclude with a few words about where we're going next in terms of follow-up and programming. First, some quick acknowledgements. Most important to our panelists, Drs. Weinstock, Heiger, Bernays, and Schultman, and especially Ethan Moscoop, your expertise and time that you generously gave to us is certainly incalculable in terms of its value. To Jermaine Wong and Jim Forsyth, our brilliant tech facilitators, I highly recommend them and their services to anybody. And to our staff members, Emma Savitz, who's our administrative backbone, and Gretchen Marks Brandt, who really put heart and soul and sweat equity into this program. We know that synagogue life is both about physical space and transcending physical space. Today's program is, of course, about the building and about the gathering, but what we will be offering in the future really is addressing both of these aspects of community life. And we will be looking forward to programming about high holidays, about tech resources, and a whole host of other things. And most important, we're going to be sending follow-ups and posting follow-ups on our website related to the topic of today, as well as disseminating answers to questions that have not been fully addressed or that are outstanding. Most significantly, I want to highlight a webinar that we have next Wednesday, June 3rd at 2 p.m., which is part of our President's ZAF Memorial President's Leadership Forum. It's called Models of Collaboration, and it is designed for synagogue leaders, rabbis, presidents, lay leaders, and executive directors thinking about best practices in their work. So look for announcement and registration for that. And finally, I want to wish you all a Chag Shavuot Bari V'Sameach, a Shavuot celebration that is both joyous and healthy. Thank you all and have a wonderful day.
Thank you.
Thank you all.
Thank you.
Thank you.
Stay healthy.